Hello and welcome to Uppsala Learning. This short seminar is going to take you through intra-articular medication in the canine, and we're welcomed by Karen Cook, one of the Uppsala vets, and she'll be taking us through this presentation. So thank you, Karen, for giving up your time and taking us through this talk. So over to you.
Okay, thank you, Greg. Hi there. So I'm one of the small animal vets at Uppsala, and I often go out to practices and teach the technique for intra-articular injection. Kind of by just walking you through each joint, hopefully you're going to gain some confidence and actually then start trying to think about trying it yourself. So start off with so preparation is really important. So first of all is actually the patient does need to be ideally under GA or sedation. So if you're just starting off out, then start off with GA. Also, if the animal's really painful, you are going to be manipulating these joints when you're injecting them. So if they're painful, if it's a particularly difficult joint, then just pop them under GA. It's going to be less strain for you, and then kind of the time constraints of sedation. So the area needs to be surgically prepared. Just try and reduce any chance of introducing infection to the joints. And for the kit that you need, very basic. So into needles, some different sizes depending on which joints, what size of animal, and spinal needles. These are going to be needed for your larger animals when you're doing the hip joints, for example, for your larger breeds to be able to actually get into that joint. So there really can be sometimes really deep joints there. And then lastly, a 5 ml syringe for you to aspirate the joint fluid to actually prove that you are definitely in that joint. If you've got joint fluid, you know you're in there. So if you're going to be injecting anything in, then you're going to be knowing and it's going in the right area. Result. So we're going to work through all the joints separately. So all these pictures are kind of from Companion Animal Health. So thanks to them. And then we've got some videos that were recorded by Central CPD. So, so a mix of both there. So this is first one's looking at the landmarks and actually kind of knowing your anatomy of each joint and all the landmarks is really important. So ideally you need to find the acromion process, drop off the bottom of that, and then kind of the needle goes straight in perpendicular to the joint there. So this video actually is Stuart Carmichael talking through when I was first learning the techniques, and he'll talk through each stage with you.
Synovial fluid collection from the shoulder joint. So the first thing we need to do is trying to identify the anatomy. The landmarks allow us to access the joint. So we want to try and identify the boundaries of the scapula and mainly the acromion process. Can we do that?
The acromion process.
Okay. Let's find the greater tubercle of the humerus.
Yeah, just there.
So we can see the distance between there. So we know what the joint is. And what we're going to do is, using that acromial process as a landmark, we're going to walk the needle off the distal part of that and direct it slightly caudally. And we're going to put the needle in without the syringe attached until we access the joint. So off the end of the acromion, perpendicularly down.
Hit the bone just there.
Okay, just keep on, just move gently backwards and forwards, see if you can find the joint.
Yeah, right in there.
Yep, that looks good. So see if we can aspirate some fluid.
So I can find the shoulder joint is much deeper.
Okay, so in this case, we've got some blood coming through, which actually would spoil our sample if we were trying to analyse it, but at least we know we're in the joint because we've got fluid there, so we could inject.
Okay.
Okay, so that's the shoulder joint. So often I find actually you do need to direct a needle slightly caudally, and also actually it's much deeper than what you think it's going to be as well in a lot of these cases.
And in your experience, Karen, what size needle would you typically go for? Because that shoulder joint, as you said, is quite deep. So like a 5/8 needle is not going to be enough. So what, an inch, inch and a half?
Yeah, if I go for an inch needle, will be fine. In the really large breeds, then sometimes kind of inch and a half, but kind of most cases, then kind of inch would be.
Okay.
Right, so the elbow joint. So there's a couple of ways to actually get into the elbow joint. So, and actually it's going to be operator preference. So I prefer the medial aspect, whereas I kind of know some of my colleagues do prefer kind of the lateral aspect. And it's a case of just finding what works with you, what position works best for you, and kind of that comes with practice. So this one's showing kind of actually entering the elbow joint from the medial aspect. And actually, so these pictures are really useful because actually you can see kind of in some cases like how big the joint is itself. And actually there's not just one place that you're going to be able to get into that joint. So your kind of main landmark for the elbow from the medial aspect is the medial epicondyle of the humerus. So kind of feeling that and then kind of dropping down into the joint. So this one is looking at the lateral, so entering the joint from the lateral aspect, and Stuart's kind of will talk you through that now.
Okay, so it's synovial fluid collection from the lateral aspect of the elbow joint. Right, so let's find our landmarks here. So again, what we're looking for that little lateral compartment on this side of the joint. We can feel for the lateral epicondyle, the medial epicondyle, so that lets us know where the humerus is. Mm-hmm. Feel for the proximal olecranon and the tendon of the triceps. Yeah. And what we're going to do is try to introduce the needle, being directed by the olecranon into the olecranon fossa, just going on the medial side of this lateral epicondylar ridge. So as near to the olecranon as you can get caudally. Higher up. Let's get the whole thing in view. Okay, so again, show me where the lateral epicondyle is. Use that, grip that yeah. Both sides.
Yeah.
Right, and then direct in on that. And secure your humerus with that so it can't move away when you put the needle in. Now you should be able to just feel that sliding in. Yeah. Yep, to the joint. Fluid. Perfect. So it's a good sample, but it looks blood tinged. So again, this gives us the correct location for injection, but unfortunately, we won't be able to submit this sample for a cell count if that's what we're interested in.
Okay, so that one's the lateral aspect. So the next one will show the difference kind of with the medial aspect. So with all of these joint injection techniques, if you can practice on a cadaver first, get your confidence up, it really does help. And actually, the more you practice, kind of the easier it does become.
So synovial fluid sampling, medial aspect of elbow. Let's find the landmarks for this approach, and kind of the main director for us here is the medial epicondyle. We can find the medial epicondyle, and then we know that just a short distance below that is the joint space. And what we have to do is try and open this up by almost kind of flexing or stretching the joint, this limb laterally to open the joint space up. In bigger dogs, putting a sandbag underneath this actually facilitates this. So I will grab the leg for you and try and open the joint up. Okay, so not much fluid there. But if we are happy that that's in the joint, then we could inject. We're not going to get enough of a sample there to do anything with, and get a little bit of blood by the looks of it. So again, not suitable for cell counts.
Okay, so the elbow joint is one of the more common joints to be injected. So actually, kind of just having that practice and kind of being confident, kind of with actually getting into that joint, without having to kind of realign and and cause any further damage within that joint, then that's that's a really good kind of way to.
In your experience, if you've got a more advanced OA joint, what complications you got to run into, what difficulties you got to run into? Because all too often when we see these in textbooks or we see them, in cadaver training like this, they're normally quite normal joints. But that remodel joint does throw you out quite a bit when you approach that. So what are you going to expect when you're going into a remodel joint?
So absolutely. So actually, a remodeled joint, then you're going to have osteophytes, kind of in a lot of places. The bone's going to be uneven. So actually, getting into the joint can be much harder. So, if say kind of when you're first starting out, actually try not to have your first case as one of these really advanced OA cases, just because it makes it really hard for yourself. But actually, once you've got used to kind of doing more cases and actually I suppose trying different ways of getting into the joints, so you know that actually if you can't get in one way because there is so much remodeling, you know that you can get in another way.
I've certainly seen in practice just having the patient's radiograph at hand.
Yeah,
if you've
that
got
can
it
really
in
help.
theatre, you can put it up, or God, the days of putting it up, showing it, showing age now. Actually visualize that remodeled joint and then trying to triangulate what you're looking at down to the joint, knowing where you might be getting difficulty in coming round to a place that you might be able to get back in.
Yeah, absolutely. So, and actually, kind of that can also help to make you realise actually what large area in some cases that you have to be able to actually get into that joint. So, kind of that can really help. And so, if you have that confidence doing it on both aspects, especially so with the little elbow, then if you are struggling one way, then you know that there is another access kind of area that you can go in.
Okay.
Right, so carpal joint. So actually, this one, so you can feel all the kind of individual layers there. So it's important that you flex this joint. So to actually kind of just to make those and kind of the different layers of the joint be clear, so you can actually feel them. So with these ones, you're going to get very little joint fluid out normally. And so it's not a massively kind of over-treated area, so kind of it's not one that is commonly treated. So, but actually, it's a very simple one to do.
Yeah, I think again, I've certainly seen one of these, a lot of these that they're difficult to flex because of remodeling as well. So
yeah, they can be. Yeah. Right. Let me do this one.
Okay, synovial fluid collection from the carpus. When we approach the carpus, this is quite a simple entry because we actually can feel the joints and where we're going to insert the needle. So we're going to collect from the antebrachial carpal joint. So what you want to do initially is flex and extend the joint, identify where that proximal joint is. Our target is right in the center of that joint, so we're going to flex the joint to open it and then insert the needle, then slightly extend the joint to allow us to collect fluid.
So I can feel it just in there.
Yeah. Okay, and we just slightly extend. So that looks if you're in the joint, this stuff coming out. Do you feel the suction there? Which shows that you're in the joint because you're actually pulling against the synovial fluid.
It's actually deeper than what I thought it would be as well.
Yeah.
Okay. So that's the main forelimb joints. So you can inject the interphalangeal joints as well. So haven't shown it on this video. So, but again, kind of very small amounts, kind of into those joints.
Okay.
Okay. So
onto the hip joints. This is one that a lot of people find difficult, especially in your kind of later grades of osteoarthritis, due to remodeling. Also, kind of you've got your dysplastic hips, that can change how things feel. And also, actually, this is kind of probably the main joint where you can't actually feel where the joint is itself. All the other joints you can actually can feel or have a really good idea, kind of where it dips down there. So, but with the hip, you can't. And actually, in a lot of the larger dogs where you're treating, so it's surprisingly deep as well. So actually, kind of actually getting the right length needle. So sometimes it can be a spinal needle that you need there, and actually, so getting into that gap there. So as you can see on the screen, so your main marker is the greater trochanter. And actually then kind of knowing that you've got your acetabulum that's kind of running around there and actually getting it into that space. So a lot of this is going to be actually positioning and getting it in the correct position. So you're opening that space up as wide as possible to be able to get the needle into the joint there.
It's almost that, sorry, it's almost that positioning that you would have to concentrate on for getting a good radiograph, isn't it? So any changes in angles is obviously going to, obscure or alter the quality of the radiograph. And I think the same is applied here, really, isn't it? So all of those aids or the idea that you got with positioning that pelvis applies to this.
Yes, yeah, no, absolutely. So unfortunately, this is the one that we haven't got a video of. Kind of, I'll talk through what I do kind of in this position. So I tend to get my thumb on the greater trochanter, and saying kind of the area kind of where kind of you're looking to inject is kind of from the if you have the femur kind of running kind of straight down from the pelvis, and you're looking so a bit like a clock face, so 12 o'clock's the top, and then kind of going cranially kind of in front of that. So I ideally don't want to go any further caudally because you've got the sciatic nerve running down there. So we're aiming kind of between that 12 and about the kind of the 10 to or 10 past position, kind of depending on which side that you're on, but in the cranial, kind of cranial to the joint there. So some people walk down the neck, the femoral neck, and actually then drop off the edge. So kind of, whereas actually kind of other times you can just kind of put it in there, wait until your needle actually touches the bone, and then try and open that joint up, and kind of do that by abducting it out. So basically it means that you're trying to twist and open that joint outwards. And it means then kind of the needle should then slide in into the joint, and then you can get joint fluid from there.
Yeah.
Okay.
Yeah, I think this is another one where I think the radiographs are quite important to see how shallow that actual joint can be when you're going in, and also again where it's remodeled, where you might have to adjust where you're putting your needle.
Yes. Yeah. And so some of this kind of smaller breed dogs, so somewhere actually kind of got severe hip dysplasia, it's very, very easy to slip off the bottom of the pelvis. So kind of going ventral to the pelvis there. So actually kind of you don't want to go too deep in that case. Otherwise kind of you'll be kind of running kind of straight kind of ventral to the pelvis and kind of not hitting the joint capsule at all. So if you think you're going too deep, come out and start again. So this is one where actually it's really, really important to have that practice beforehand, before doing one. So sometimes you can surprise yourself. So you kind of go in, and actually, which is why you kind of, if you go in, you think you might be in the right area, always pop a syringe on and test to see if you've got joint fluid there, because you can sometimes surprise yourself and just get straight in there.
Yeah. Okay.
So this is just a picture showing kind of the positioning there, kind of, so it's my thumb on the greater trochanter. Just depending on the size of the dog, sometimes it's kind of, I'll be going in with a needle right next to my thumb. Larger breeds, kind of it's about a centimetre, kind of, if not more, away from where my thumb is on the greater trochanter there. And you can see on this position, I'm about the kind of 10-2 position. So if the dog was on the other side, so it's right leg, so that would be the 10 pass position, kind of if you're looking at the face of the clock there.
Okay, and depth again, I mean, how far are you going to go in before you're expecting to hit joint? I mean, I know you talked about, you know, if in doubt, you could literally from the greater trochanter walk down the neck to the point that you hit it. But if you're going off that, you know, about a centimetre, if it was like a Labrador at the 10-2 position, you're dropping down, let's think Labrador, how far are you going to go down before you're actually expecting to hit? Because it's quite a depth, isn't it?
It is, yeah, it can be. It depends a lot on actually kind of muscle mass as well. So
yeah, and fat, yeah.
Yeah, so actually if the dog has got massive amounts of muscle atrophy, then kind of actually you'll be hitting bone pretty soon. So actually if it's still fairly well muscled and you're getting in there at quite an early stage to try and you know, prevent kind of getting kind of to those further stages, then actually sometimes, so I've kind of with the larger breeds, I've been in kind of with the full length of a spinal needle kind of by before actually right into that joint there. So kind of some of them, if they've got a lot of muscle there, it's much deeper than what you think. Again, this is kind of just kind of showing drawing, so kind of actually kind of where you're aiming for. Oh, sorry, I have got a brief video. So just aiming there, kind of just, so this dog was a medium breed dog. And so you can just opening that joint up by manipulating the limb. And then the needle just drops in that a little bit further to get inside the joint. So a lot of it's done by feel. So actually kind of once you've done a couple, you know what it feels like to get into that joint. And then and then often then once you've actually let that leg go, it actually grips onto the needle. So it doesn't pull out very easily as well.
Yeah.
Right, so the stifle joints, again, a fairly common joint to be treated just because of the amount of injuries to the joint. Number of dogs that have had surgery to the joint as well, and then developed osteoarthritis. And so actually kind of with this, I suppose the challenge with this joint is actually just trying to avoid the fat pad. So if there's, so quite often you're treating these joints when there's a lot of effusion, in which case you go in and actually it's very easy to know that you're in the joint. Most of the times actually you need to make sure that you're getting in and kind of you're not just injecting just straight into the fat pad there. So with these ones, I try and aim kind of to one side of the patellar tendon. It doesn't matter whether you go laterally or medially. And so kind of if your heads are kind of in and then up towards underneath the patella, and then you're away from the fat pad there, and kind of from that point to be able to kind of aspirate joint fluid. So this one has got video, so I'll just, just play that.
So synovial fluid collection from the stifle joint. So anatomical landmarks here, we're looking for the tibial crest, tibial tuberosity, straight patellar ligament and the patella. So we can flex and extend the joint so that we're sure that these things are where they should be. And what we're going to do here is we're going to insert the needle almost just off the top end of the tibia, on the lateral side, directing it behind the straight patellar ligament, aiming to go in behind the patella. So we start off with the joint slightly flexed.
There's the top of the tibia.
So you should feel that go through into the joint, and once you think it's in the joint, let's extend the joint to take the patella away from the distal femur, and then just drive the needle proximally. And hopefully we'll be in the joint space. There you are, we've got fluid there, lots of fluid coming out there. Again, a little bit blood stained, but certainly we're in the joint. The blood staining may mean we can't do a cell count, but certainly that amount of fluid is 4 or 5 times what we would expect in a normal joint. So we're sure we're there. Good.
And actually, on a quick note about the amount of joint fluid in there, say if there isn't a fusion present, but if you're going to be injecting something in there, then you want to be able to take some of that fluid out. Otherwise, you're going to be putting a kind of extra volume in there, extra discomfort. And actually, if you can remove some of that fluid, it's going to give some instant relief to the patient as well.
So just to confirm, Karen, your injection technique is really not to go anywhere near the fat pad. You're actually almost trying to go, underneath that patella, aren't you? So you're not trying to avoid the fat pad by going through it or adjacent to it. You're actually not even really going anywhere near it. You're kind of going on top, aren't you, to place your needle underneath that patella and then extend and create the space. Yeah.
Yes. So kind of just say by that, that you say also kind of if you're going to the fat pads, then you're not going to get the joint fluid back either. Yeah. So by just going under the patella there, and you can feel kind of when actually you go in, you can feel exactly where the needle is. Just avoid that area kind of where you don't want to be injecting it into.
Okay.
Right, so last of all, got the hot joint. So with this one, so you're going to be looking at going in from the lateral aspect, lateral aspect, and kind of heading. So with this one, I find it's really important to get the angle correct. So actually having the joint kind of at a 90 degree angle. And then, so the angle that I go in with the needle, it's kind of almost kind of bisecting kind of straight across at a 45 degree angle into that joint there. So I'll play the video and it'll become clearer.
Okay, synovial fluid collection from the hock. So we're going to use a lateral entry point here. Landmarks, we're looking for the point of the calcaneus, and the key thing is the lateral malleolus. So that's the distal end of the fibula, and we're going to try and access the joint just to the medial aspect of that, and just sneak into the tarsocrural joint there.
That sort of angle?
That looks good. This one's where you just have to feel your way there. We're using a smaller needle and a smaller length needle here because it's a smaller joint.
How far would you expect to go in on this joint?
You can go straight in. You want it to slide in. Lovely. So bloody tap. I don't think that was your fault. I think there's blood in the joint. So again, we probably can't analyse a cell count on this, but it certainly shows we're in the joint.
Okay, so that one's quite a small opening kind of to get into there. So, but I say it's just very kind of very gentle kind of feeling around and kind of just sliding in there.
Okay.
So that's the end of.
No, thanks, Karen. Anybody having difficulty with these? I mean, some people talk about, checking radiographically if you're in the joint. Is that another tip that one might do if you're doing things like carpal or tarsal joints? Probably not as quite easy with some of those bigger joints, but you wouldn't do that?
I've never had to, so it's I think it's just practice. So actually making sure that you're confident getting into the joints that you're going into. So practicing, say, on cadavers, and actually, so with these ones, it feels really good when you're in. You know that you're in because you can get the joint fluid back. So it's a real positive test there. To say you're in. You can inject away. And actually, it's a very accessible skill to have. Actually, with a bit of practice, then kind of it's a really nice one to be able to do.
And what about feline joints? I mean, I know we don't have the same type of material like videos and pictures to show people. Is the technique any different?
No, exactly the same, much smaller. So I'll be practicing on dogs first before going on to cats. So because they are smaller, then the margin of error is kind of much smaller there as well. So, but it's kind of I tend to use probably a smaller needle for the joints. For those ones, just trying to kind of. I don't want to be going in with a big needle. First of all, I'm not going to get into the joints, and also I don't want to cause kind of further damage in there as well.
Yeah. Okay. Great. Well, hopefully that was a useful tutorial for us all. I think we'll be going into other areas of joint injection, and I know we've got a tutorial coming up where we're going to use the insight needle. I think we're going to play around with the insight needle, aren't we? And I know we've got videos from Sherman Knapp showing how he uses that same needle approach into the elbow to then place the insight camera in there to have a look around as well. So these are things we can look forward to in the future tutorials as well. Okay, so thank you, Karen, and yeah, look forward to the next tutorial.